Thank you, Naren. It's a really pleasure to be with you, and so nice of you to speak such good words about me. I'm really overwhelmed. So the topic to me is post-refractive surgery. Maybe, I mean, I had to decipher what exactly, and I asked Lucy that what exactly you want me to speak. She said, like, I want you to speak on the post-refractive surgery IOL power calculation. So basically, all of us are going to come across such kind of scenario, and we already have come across, but we are going to come across more and more such scenario where people will come across to you who have undergone refractive surgery in past, and now we have to deal with them with their expectation and their IOL power calculation. Now, earlier, whenever we had a post LASIK refractive surgery patient or post RK patient or post PRK patient, we knew that the relationship between anterior surface and posterior surface is deranged in cases where you flatten the anterior surface, like case of LASIK or PRK, whereas in RK, the relationship between anterior and posterior surface is still maintained. But the cases where the anterior surface relationship is altered, like in LASIK, what happens is that when we measure the keratometric values are falsely overestimated, because the measurement is done somewhere around 3.2 to 3.5 millimeter in a zone, whereas the center part of the cornea does not follow the same suit or same curvature as it is there in that region. And hence we ended up having the hyperopic refractive error. And so many formulas. And earlier, I remember I used to sit and calculate all these things on different formula. But now, thankfully, we do not need to do such kind of thing, because we have now ACRS calculator. Now, I'm not going to go into theoretical detail of any of such kind of thing, and you all know that how we calculate these things, but I'm just going to give you practical example. What if some patient comes to you, and what if something which you have or something which you do not have? Let's take one example. A person who has undergone surgery long back and in right eye has come back with a cataract, a significant amount of cataract, which has led to refractive change, mainly due to the cataract surgery now. I mean, cataract there in the eyes now. Now, look at the scenarios. Now, what if one of the center has IOL master and has OBSCAN, and they are going to use it for the ACRS calculator, or the other center has LensStar and Pentacam, and they are going to do the same thing? What happens if we have such kind of different scenario? Let's take center one, which has the IOL master and OBSCAN combination. The combination can be anything. I'm just taken the example here. Now, when we taken the IOL master, you also have to pay attention to the N values, which is set for the machine. And here it's 1.332, remember that, because that's going to change the IOL power calculation. So let's see the data which we have from the IOL power, as well as the data on OBSCAN. We put the pointer in the center part, and we get the central axial power from there. Now let's calculate in the ACRS calculator. Now remember, in ACRS calculator, many things may not be there. There is no OBSCAN data available for the central corneal power there. Doesn't matter. If there is something else which is not available for one particular machine, doesn't matter. If the principle is similar, you can actually utilize that. Now let's see if we put the data from the keratometric data from the IOL master, which is standard and which is absolutely fine. But the place where we have to put our IOL master data, the central power, is where the Galilei part has been given. Now, the true corneal power of or total corneal power in the Galilei, where we have not used Galilei machine, but in fact, instead of that, we can put this data in that place. After that, we pay attention to the K values, as I told you that we have to adjust it here because in the machine of IOL master, it has been 1.332 as a setting. So let's do that and then go ahead and calculate. The lens power which you get averaging different formula, usually would like to take with the average as well as the minimum power what you get there. So we got somewhere around 90. Now, what if the patient had gone to other center? Now you have IOL, instead of IOL master, you have LensStar there. And instead of the topography like OpScan, you have now Pentachem. Now Pentachem has other calculation. The reason behind taking Pentachem, because we will be able to calculate many other things, like in equivalent K reading or EKR map of Holiday, we can have zonal K readings from like 1 millimeter, 2 millimeter, 3 millimeter, 4 and beyond that. So what we can do here is that we can take the reading from the center part as the central K reading, and again it's equivalent K reading, so which is like almost a true corneal power what we measure, and which is normally taken. So let's fill in the data into this thing. Now here, instead of Atlas, where it's a Placidos based topographer, we take the value from the EKR values of 1 millimeter, 2 millimeter, 3 millimeter. We enter those values there. Again, in IC system, where effective corneal power, whatever we have, in that we add the power of the center power there, or rather 4.5 millimeter power from there, and the center power we add into the 0 millimeter zone. So what happens now here is the instruments are different, but the values we are utilizing there. Now from the lens star, the values are standard, but again, remember that we have to pay attention to the K values or index, whatever we are taking, and we change the index to 1.337 and then go ahead and calculate. Well, what we get is similar power. Now think about it, two different places, two different sets of instrument, but we got similar power and the outcome was excellent. Now what if the place, instead of this thing in this place, if we had just gone ahead with the IOL master or lens star directly, well, we would have certainly end up a significant amount of hyperopia. What if we didn't have topography at all and we just had the optical biometers? Then if we calculate the lens power, well, with the IOL master, with whatever we decided and see, we have not put any other data anywhere. And if we just calculate, it still gave us the same power. And if we use the lens star in some other setting and follow the same suit, and we realize that we got similar power here. So irrespective whatever formula we use, or irrespective rather whatever machines we use, if we know that it's done properly, we still can do quite well. I'll take second example now. The LASIK was done, but we have post LASIK data available with us, so that we know that what we can utilize some other methods like historical method and those things. Now in post LASIK data, we realized that patient had cylindrical power, and now patient requires toric IOL. If you look at the data which we saw earlier, along with the topography data, the topography also showed cylindrical power, which was matching. And now if we enter the data into the ACRS calculator, similar to what we did, the total corneal power earlier we measured, we use the data from the keratometry, as well as the data, which is the historical data, what we enter here. And then if we calculate, we get a power somewhere around 9.5. Now, if this power, if we use and utilize the toric calculator, and in the toric calculator, we put that as a spherical power. Using the toric calculator, the lens power, whatever we got, and we got the significant visual outcome. So what if we didn't put any of these data, like keratometric data or the topographic data? So that means we only have history as well as the keratometry value with us. And if we calculate, we still got similar power. So what do we get from this thing? Regardless of the method you employ, if you have good biometer with us, and if we are using ACRS calculator, we surely can hit the target most of the time. And especially whenever such kind of cases require premium IOL like toric IOL, multifocal IOLs, that's where your spherical equivalent outcome would be very, very important. With this thing, I would like to thank Dr. Varun Kharbanda for his profuse help for making this presentation. Thank you.